To our next speaker, Dr. Shruthi, who's the Chief Medical Officer from Shankara Group of Hospitals based at Coimbatore, a very charming person. And let's hear her telling us how she would take care of hemostasis in DCR. On to you, Dr. Shruthi.
Is my screen visible?
Yes.
Right. I thank Dr. Chitra for having me here. Thank you, ma'am. Actually, my previous speakers have made my life a little easier by covering a lot of aspects of what I'm going to touch upon now. Now, to prevent, tips to prevent. This is a very Manipal term, you know, preventing DC war. So this would be probably in our early days when DCR was a very scary surgery, but it's actually not so bad. So what do we do for that? Now the systemic evaluation, my previous speakers have already told, Pratibha has explained in detail. I would still touch upon the hypertension, the bleeding tendencies, and the relevant investigations that we need to do. And I generally stop blood thinners a week before surgery. And if they're on warfarin, the INR to drop below 2. And as Pratibha said, the herbal concoction, yes, I asked them if they're on any herbal concoction, and it's a good idea to stop it preoperatively. Now, pre-medications, yes, I do give pre-medication. I start them on oxymetazoline hydrochloride or the Nasibian drops, 2 drops 3 times a day, at least a day before surgery. And I also give Angzit 0.25 milligrams in the night before surgery. It simply makes them to rest well and they're less anxiety the day of surgery. And I would also tell them not to stop their routine medications, their anti-hypertensive medications and all that, because sometimes the anesthetist would tell them to stop to take anything orally, and they stop even their hypertensive medications. So I insist that they take their routine anti-hypertensive medications. Now, the physician and the cardiac evaluation is very important in relevant patients. Nasal examination, yes, is important, especially to rule out if there are any polyps, mass, or DNS, or generally the appearance of the mucosa. Anesthetic support, I depend on them. Yes, like Javed said, we have anesthetists 24 hours who are there with us. So I think we are a little more relaxed when they are there. They always tell us, like, you know, don't panic, go ahead, do it. Even for our residents, when they are around, you feel a little more relaxed with what they do. I leave it to them. They use all sort of concoctions to make sure that the BP drops down, and then we operate in peace. Positioning of the head is again important. Elevate the head end. Instruments or the armamentarium that I would, apart from our routine instruments that we have, I insist on good magnification. Have a loop, so you have to see what you're doing. Tiny things matter. A good headlight. I don't generally use the cautery much, but it is good to have them around, especially the fulguration mode when you don't know where exactly it is bleeding from. So when you use the fulguration, it generally gives the collateral burning as well. So your bleeding can, to a certain extent, be reduced, and a good suction apparatus. So a good endoscope, good set of instruments. You have retractors. Apart from all that, invest on very good punch. They should be sharp and good. I generally use the malt periosteal elevator. I like them. Good blade, scissor, and the surgical sponge, the Merocell or the non-woven sponges, they're very good in absorbing blood. So the surgical technique, again, nasal packing is very important. You have to pack where it is required and to the extent that it needs to reach the place where it is supposed to reach. So you can see the sac is here. So at least it should go to that level and not somewhere close by here at the ala of the nose and stop it, or don't go below. So careful surgery, again, I use 1 in 1000 adrenaline. Careful surgery is very meticulous surgery is important. If you see most of us, most of the residents especially are, I don't know, they've got psyched up by this angular vein. It is not really, you don't really need to be very scared of this angular vein. If you see it, you simply retract it and it just stops bleeding. So just a small video on what I do. Off late, I have started, Off late, I have started inject, even for my endonasal, routine external DCRs, I do a little bit of endonasal injections. I give injections as well. So that kind of, like, it arrests the bleeding much more. I'm happy that way that the periosteum, I mean, the nasal mucosa doesn't bleed much. And not always it can be as roomy as this endoscope sometimes. And then visualize the packing. Where you need to pack is need to be visualized. And this is another patient where it is narrow, but still you can negotiate a needle and give an injection. So that kind of gives you you're sure that, you know, it is well taken care of. The same block, apart from that, I also inject transcutaneously into the sac. And so especially if the sac is a little inflamed, you know, that helps. And the routine, all this I will skip. But there is one small tip that I need to give here. When you are separating the orbicularis fibers, hit the bone and separate the orbicularis fiber. And you can see that there is a small opening created. Go through the same opening. Don't go again with the new pass. That same pass, if you go, you tend to, you know, hit the bone and then it separates out pretty well. And also, when you see that there is some kind of small feeder vessels would be there, if you look at that, bare the periosteum, this is again important. You see here, these are small feeder vessels which are here. So if they are there, you know, I cauterize it. It makes your life a little more simpler. And the angular vein, you can see a plump angular vein, just retract it. It goes behind the retractor. Your assistant does a good job by holding it there and also giving the pressure. And when you retract the sac, it is important to retract it along with the periosteum. So that way your sac is protected and periosteum is avascular. So that zone is important. So if the sac is inflamed, and then your routine punching, the punching part I will take out. And once you do the punching, I think Akriti was also mentioning about injecting. Yeah. I inject a little bit into the once the a meticulous sac flap is also important. And see here, so you have got the sac flap, which is relatively bloodless here, and this point again I inject into the nasal mucosa, the local anesthetic. And then at this point, if you want, you can pack a little more. And before you take the nasal flap, I again bulge the nasal mucosa with the bud. So that way you're protecting your middle turbinate there. So you don't inadvertently hit the middle turbinate. And you can see that it is a very gross enlarged middle turbinate. And then your routine, the rest of it is the same. You suture it and close it. So that is my small tip for preventing, and thank you very much.
Lovely talk, Shruthi, very thoroughly covered. Dr. Arvind?
Dr. Shruthi, your compliments for such a nice video. The resolution, the clarity, the hemostasis, everything, and the bandwidth was perfect.
Thank you, Arvind. I think I should tell my residents, they do an excellent job by recording with their smartphone itself. Nothing fancy, just the smartphone.
Good.
Yeah. Is there anybody nowadays ever has torrential bleeding, or it doesn't happen at all?
I have had my share of bleeding. Yes, it can happen. Main problem that I have found is the intraoperative rise in the BP. So that is what I feel at that point. You know, you're panicking. Your patient can hear you panicking, and that is what is important, I feel. And that is when our anesthetists, they take over, and then, you know, somehow they do something and just reduce the BP, and then the job is well done.
Okay.
I use, as Javed said, I also use a lot of adrenaline. So I think that way it is quite all right. I pack with adrenaline. I inject again with xylocaine with adrenaline. Again, I give injection when I'm doing the nasal flap. So all that has helped me.
I noticed that when you took the nasal mucosal flap, there was no nasal pack. So do you remove it?
No. When I do that, I've removed in between there, but I always repack with the nasal mucosa, and then I bulge that. so that, there is something behind that. So when I take an incision, I don't hit anything, any vital structures behind, or just mainly the middle turbinate.
I'll just pass a question to Dr. Shreya Shah. Do you have any additional tips, madam, on hemostasis that you do?
Yeah, actually, Dr. Shruthi showed a very nice external DCR, but what external DCR I am doing is I'm not opening, I'm not making any flaps. I'm still doing the old technique, which was power implantation, but slightly modified implant we have designed. So I just make an incision below the middle palpebral ligament, and already sac is inflated. So I know that my blade will definitely go into the sac. My another cannula is there into the sac through the lower canaliculus. So your blade and cannula touches, so you're sure that you are into the sac. Same way, I have done my study with 90% of success rate, which is cannula DCR, what we do for an emergency-based internal drainage of the sac, when you need to clear out the pus and everything into the nose, and you can proceed for other surgery. So that based on my knowledge of cannula DCR, I make it 45 degree. I do cannula DCR, I confirm on table where it is patent, then I just simply drill. So now drilling itself is, before drilling, I definitely inject again into the periosteum that Dr. Javed said, adrenaline and lidocaine. And then I just simply drain, and we have our own device, implant. I put that implant, and there is no bleeding I have seen. Yeah, but sometime when blindly, if you are putting a blade, there is definitely angular vein cut, but don't worry about it. The moment you drain and you put the implant, it usually goes side, and simple pressure, what I have felt, that surgery usually I finish in 7 minutes, that to 4.5 millimeter incision.
I think we should have a video talk sometime for that.
I'll definitely share the video with you. That is 4.5 millimeter incision on skin, and nothing, we don't have to do anything. It's as good as external DCR with implant, and I confirm all the implant through the nasal endoscope also, which is properly placed and cleaned. And sometimes it is plugged, then we have to clean in OPD with endoscope help.
I think our take home should be a thorough preoperative evaluation.
And what I'm sorry to interrupt, what she said, hypertension is definitely what Dr. Shruthi said. When you are becoming panic, and again that bleeding, and again that hypertension, that is a vicious cycle. So that time, if you have to have not even anesthetist, but if your resident can do something to lower the BP, that definitely helps you.
And again,
Arun, can I get a couple of points in, because the main reason why general ophthalmologists in most parts of the country do not do a DCR is bleeding, right? Most general ophthalmologists are trained in ophthalmology. They have done DCRs as residents, but someday they stop doing it because they come across a patient who has bled, and that's a nightmare situation. Ophthalmologists have a very, very low threshold for bleeding. It's lucky most of us don't faint at the sight of blood. When you compare us with ENT surgeons or plastic surgeons or orthopedic surgeons, blood all over, they maintain their cool. But ophthalmologists in general have a very low threshold for bleeding. So the main reason why general ophthalmologists do not do DCR and bring us oculoplastic surgeons in for these operations is bleeding. So I think it's important to emphasize that before you start DCR, you should be equipped. If you start bleeding and there are the things available are not enough for you to stop bleeding, that's when you panic. You can in fact even kill the patient theoretically in that rare event. So a good bipolar cautery, you can have a radio frequency cautery, a bipolar cautery. You must have something like Abgel, which helps you to arrest bleeding, or something like Surgicel. We'll not go into details, but if there's time for discussion, we can add those on. And increasingly, I have found that when I work on bigger areas and larger areas and bigger, apart from lacrimal surgery, fibrin glue available in most theaters. I think in multi-specialty hospitals, it's used widely by hepatology, neurosurgery. Ophthalmologists also use it mostly for pterygium surgery. But fibrin glue is also an absolute boon. In addition, with the advent of nasal endoscopy, we know where the blood is coming from. Compared to earlier, when nobody knew nasal endoscopy, there's blood oozing through the nose. We don't know where it is coming from and how to deal with it. So today, the kind of torrential bleeding which panics an oculoplastic surgeon, I think is very, very rare. So once you're equipped with these and bone wax, very rarely used, but if your bone is bleeding, you can, nothing goes into that area, your cautery doesn't go, your abgel is going to get washed out or come out. Bone wax applied forcefully gets into the little crevices in the bone from which bleeding is there. So if you have all these in your theater, then I think you can very boldly go ahead and almost never come up with serious bleeding. But I just have to put these points.
Yes, thank you very much, Dr. Ramra Mohan, for your the very important